Good morning, Professor Goldstone.
Good morning, sir.
Now, you're talking to the audience in front of you, but be aware that there is a rather larger audience who will be watching you online.
Yes, sir.
The first step is to ask you to take the oath. Mary will ask you to take the oath in a moment, and then Miss Scott will ask you some questions.
Thank
Mary.
you.
Please state your full name.
Anthony Howard Goldstone.
Take the book in your raised hand and repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the
and
truth.
nothing but the truth.
Professor, I'm going to start off by running through the details of your career with you. So your first post was as a house physician in medicine at the Chase Farm Hospital in Enfield in February 1969. And then you took up a post as a house surgeon in the Edgware General Hospital in August 1969. Is that right?
That's correct.
You then became the resident clinical pathologist at Guy's Hospital in February 1970, and then in February 1971 took up a post as registrar in haematology at the Western General Infirmary in Edinburgh.
Correct.
You then, in June 1972, while you were still, is this correct, a registrar in haematology, also became the Cancer Research Campaign Research Fellow in clinical immunology at the Edinburgh Royal Infirmary.
Yes, the two were done at the same time.
And that was a post, that Research Fellow post was from June 1972 to June 1973. And then in June 1973, you left both of your posts in Edinburgh and moved to the Addenbrooke's Hospital in Cambridge as a senior registrar in haematology.
That's correct.
You then took up your post at University College London Hospital, UCLH, as consultant haematologist in 1976.
That's correct.
And that is a post that you held until 2011.
Correct.
And while you were in post, while you were working as consultant haematologist at UCLH, is it right to understand you're also the medical director of UCLH?
That's correct. During a period of that time, UCH, which it was at that time, appointed its first medical director in 1992, and I took up I applied for that post and was successful competitively in obtaining it, and that lasted for a period of 8 years until the year 2000, when I left it because we had achieved the agreement to rebuild the old hospital into the present new hospital.
And while you were undertaking your role as medical director, were you also working as a clinical haematologist?
Yes, it was approximately 50-50.
You, as I understand, retired from clinical practice in 2015. Is that right?
Yes, what happened was I retired from NHS practice in haematology at UCLH in 2011 because I was invited to take up the chair of the board at the Royal National Orthopaedic Hospital with a remit to get it rebuilt, which is what happened. I was told at that time that you could not concurrently do an NHS consultant post and be the chair of a trust board. There was some dispute about that later. So I left the NHS post, chaired the board at the Royal National Orthopaedic, and continued in private practice until 2015, when I ceased seeing patients clinically in private practice.
And currently, is this right, you're chair of the HCA Cancer Department?
Yes, I work for a large organisation called HCA in the private sector, and I'm the chair of the Cancer Department, which is a strategic post attempting to integrate the cancer services across several separate, previously freestanding hospitals. So I remain registered and revalidated and appraised each year, but I am not seeing patients.
And you have an honorary consultancy position at UCLH?
Yes, I don't think it's been altered since I left, but there's no recent activity associated with it, but it seems to be still there, which I'm happy about if it is.
You've also, your witness statement tells us, have been a member of the British Society of Hematology from 1975, and that continues to date.
Yes, one tends to join it when one gets one's final accreditation in haematology before a consultant post, and yes, I'm still a member.
That you were, between 1992 and 2000, Medical Director and Chairman of the Clinical Directors Group, UCLH NHS Trust.
Yes.
Can you tell us a little bit about what that group was and what that entailed?
Well, also for the first time during that period, UCLH appointed clinical directors in each of the specialties, medicine, surgery, pathology, and in the subgroups of medicine like neurology and cardiology. So those clinical directors were also appointed by competitive appointments, and it was the duty of the medical director to discuss and agree clinical pathways integrated in the various specialties, and particularly governance issues. So you were the senior clinician with a remit to address any of the governance issues of the other departments.
And then between 1988 and 1992, you were the chairman of the North East Thames Regional Haematologists.
Yes, that was a much more informal group which met, as I recollect, and I have no paperwork in relation to this, approximately quarterly with all the consultants in the northeast Thames London region to discuss issues of clinical pathways, trying to assure that we all approach things in the same way, issues of staffing, which has always been a difficulty at the district general hospitals, issues of training where the juniors would rotate through some of these hospitals, and various issues of this nature.
And so while you were chair between 88 and 92, is it right to understand you would have attended meetings outside of that period?
On the whole, as far as I recollect, I only attended on a regular basis during the period I was chair, because at previous periods, the director of the laboratory, Dr. Richards, attended on a regular basis, as far as I can remember.
And then you also were president and co-founder of the British Society for Blood and Bone Marrow Transplantation, president between December 1998 and December 2000. And president of the British Society for Hematology in 2001.
Yes.
Before I look at in a bit more detail at your clinical practice, I'm just going to ask you some questions about generally about your knowledge of risk of viral transmission via blood in the early years of your training. So during your haematology training, what were you taught about the risks associated with blood transfusion and the appropriate use of blood?
This was particularly during the two periods, first of all as registrar in Edinburgh under the charge of Dr. Norman Allen, and then as senior registrar in Cambridge with Professor Frank Hayhoe and Dr. Chalmers and Dr. Seaman. I think we were taught that there is some risk to blood, that the only real virus issue known in terms of transmission in my early days of training before I got to UCLH as consultant was hepatitis B, and that this was of low prevalence in donors, occurred sometimes in recipients of blood, but on the whole, after a brief illness, they survived it and went back to normal. That the overall outcome of the blood transfusion, even though a very few people were infected, was usually positive. In terms of the appropriateness of transfusion, I think we were taught, and most of this was bedside or a clinic teaching, although pre-examination we went to more formal kind of intensive teaching sessions. We were thought to consider blood transfusion seriously, that in a kind of parallel to any drug or pharmaceutical agent, that the use of it had to be considered carefully. The amount of it had to be considered carefully, and also there was a special element to the donation of blood, which gave you a kind of responsibility to the donors who had offered it to use it in the most sensible fashion.
Were you aware of the dialysis-associated hepatitis outbreak in Edinburgh that occurred shortly before you arrived in Edinburgh to take up your haematology post?
Just about aware, but I'm sorry to say nothing of the detail.
And so, is it right to understand from that episode wouldn't have had an impact particularly on your understanding or knowledge of the risks of transfusion-transmitted hepatitis?
I think before I got there, it would have permeated through strongly to the understanding of the senior members of department, and since Dr. Allen was a very serious individual, would have affected his outlook in terms of what patients were given. But as I'm sure others have told you, this is a very long time ago, and in both Edinburgh and Cambridge, the kind of philosophy of giving blood was very serious.
Can you just help me with this? What level of contact was there, what flow of information was there between the Edinburgh Royal Infirmary, which I think is where the outbreak occurred, and the Western General?
Sir, it's like many of these instances of two big institutions in the same city, where some of it is competitive and interchange is excluded. But I think in relation to this, I would say total exchange of information, because it would go back to the involvement of the transfusion centre, which would be supporting them both.
Yes, thank you.
Turning then to your time at UCLH, you have said in your witness statement that you were appointed as a consultant with some interest in blood transfusion. Does that phrase, with some interest in blood transfusion, have any particular meaning?
I will try and explain it to you. It was a device for them to get an extra post to offer a greater cover in blood transfusion, which was largely done by my senior, Dr. Richards. He was away very frequently in the work that he did for the College of Pathologists, and it was thought important that the covering of that area of transfusion that had somebody else there. I was trained as a regular senior registrar with an emphasis on malignancy, with some training in blood transfusion, but by no means an expert. But I was the reference point to the senior technical staff when Dr. Richards was not available. The main reason to bring me was to set up a leukemia unit.
And so is it right to understand that in 1976 until a period a few years later, you were carrying out the general hematological work as well as treating those with malignant hematomas?
Yes. So Professor Pranker was my clinical chief, was a professor in the Department of Medicine. He was the clinical hematologist of the hospital. That was not done by the laboratory service itself in those days, in the mid-1970s. And he was preoccupied as dean with securing the future of the medical school, which was then solely within UCH, because he saw it as a small, fragile entity which might not survive the future, and was attempting to get it taken within UCL, the main university. So he was doing that. He was doing clinical hematology, and we also were doing, on what used to be called the firm, medical take. That means taking emergency cases in general medicine through the door on a particular day of the week. So I was supporting Dr. Richards in the laboratory. I was supporting Professor Prankard on the clinical ward rounds in hematology, and also on dealing with the general medical cases that came through the front door of the hospital, because we were at that time one of the firms doing what was called take. Unfortunately, and it was widely reported in the national press, sadly, Professor Prankard had a big family tragedy where two of his children, both qualified doctors, were lost in an incident on African safari, which was attacked by a terrorist group. And of course, not surprisingly, following that, which was, I think, about 2 to 3 years after I arrived, his overall engagement in everything that was going on fell rather precipitously. So I was doing a lot of things. The support of Dr. Richards in the laboratory, the support and the takeover from Professor Prankard clinically, and trying, not least, to set up a serious specialised leukemia unit.
And I'll come on to the setting up of the specialised leukemia unit, but just staying with the other aspects of your
Yes.
role at that stage. You've described in your statement how at that time it was generally the clinicians from the other departments, such as gynecologists or obstetricians, who were making decisions about transfusing their own patients, and they were coming to you for specialist input. Is that accurate?
Yes, that is generally correct. So what happened was that much of that was routine requesting in their own department directly with the blood transfusion section of the laboratory. And we had some very senior, serious people in the blood bank. If they had a request that they thought that I don't really understand why they need to have this, then they would complete the triangle by including Dr. Richards or myself to offer advice.
And were those, when those requests came in that looked out of the ordinary or were not easily comprehended, were the technicians in the laboratory, the scientists, using blood ordering schedules or the like at that stage, or was it just on the basis of their experience?
Again, it's over 40 years ago, and one of the things that I need to tell you today, which you will know already because you have interrogated UCLH separately, they have no paper records from that era whatsoever, because I made a separate inquiry when you contacted me. So the answer to your question is yes, I think so. I'm almost certain that we had schedules, but I cannot 100% confirm it.
And again, in terms of, are you able to assist at all in terms of the general philosophy or approach that you saw from your clinical colleagues in other specialisms in relation to their approach to blood transfusion at that time?
Yes, I can say something about that. Of course, given a diverse group of individuals, it's difficult, it's not reasonable to generalize about all of them. But there were some who felt, and indeed it was sometimes true, that they knew more about the requirements for blood and blood products in their own specialist area than perhaps anyone in the hematology department did. I don't say all that in a negative way, because the departments like obstetrics and neonatology were very highly regarded and reference centres for much of the UK. So there were people in some of those departments from whom one learned some things about blood products oneself. So on the whole, you were dealing with serious, responsible groups of clinicians, but occasionally there was perhaps repeated ordering from a subgroup or an individual that you thought was not reasonable, and that was the time to to go and engage them rather more strongly.
And what was the response to that kind of engagement?
Well, again, it was variable, but on the whole, you were dealing with a largely responsible group of senior clinicians who would make change if you, not because you told them, but if you showed them what might be the evidence at that point and what other people had found. So on the whole, people were amenable to change after discussion, which was evidence-based where that was possible.
And that kind of material to show what the evidence was would it from clinical studies and from guidelines and the like?
Yes.
Can you are you able to help us with whether or not supplementary iron was available in the early years of your consultancy practice, so in 1976?
If we're talking about parenteral or iron injection or intravenous iron, I'm not certain at what time that came in, but certainly oral iron was available many years before that. From the time that intravenous or parenteral injectable iron came in, it seemed attractive because it would raise the blood count more quickly than oral iron, but it always had a reputation for a potential very difficult allergic response in the recipient, sometimes anaphylaxis or real shock. And I have to tell you, and that reputation as being a kind of tricky drug stayed with it for many years until very, very recently. So in some circumstances, a clinician might go for blood rather than parenteral iron because he or she had a problem with it. What I have to tell you that a family member of mine put on parenteral iron, some years like intravenous iron, some years later, had a very, very severe allergic response, which I have never forgotten. But overall, I think that iron supplementation intravenously was perhaps used less than it might have been because of anxieties about side effects.
And in those early years of your practice as a consultant, were you using oral iron tablets as an alternative to pre-surgical transfusion, for example?
As I remember, the balance was much more with oral iron, yes. I can't give you the exact breakdown, but yes.
Moving then on to your work in hematological malignancies, you've told us that one of the main reasons for going to UCH was to build the department there. And your witness statement tells us that in 1977, so shortly after you arrived at UCH, you went to America to train in bone marrow transplants. Can you tell us a little bit about where you went and what you did there?
Yes, certainly. So, as I got there in early '76 and reflected on what a really high-class leukemia unit would need, it was immediately obvious as I looked at other kind of specialties which were not modernizing enough, like the renal side never went to transplantation and therefore other work went elsewhere. The cardiac side of UCH was never strong in surgery and the work went elsewhere. And it occurred to me, and it was very much my own personal thinking at that time, that unless the leukemia unit also involved a transplantation unit, it would not fly, as it were, especially amid the competitive environment of London teaching hospitals. So I asked Professor Prankard, this was during my first year there, I discussed this with him and said the place to go was Seattle. That was the leading center in the world. And of course, the one led by the individual who subsequently got the Nobel Prize for it, a chap called Don Thomas. And they were very smart because they welcomed guests from overseas for training for all sorts of obvious reasons, additional labor, marketing, and of course these people would go home, set up their own units and send them the most difficult cases. So I went there in early '77. I was already a consultant, so I couldn't go for very long. I went for a couple of months and worked kind of like a houseman again, right on the ground, looking after the very basics of the patients and being supervised by people who, in my own environment, would be junior to me, if you see what I mean. And I was fortunate to have the number two there as a personal mentor, a guy called Dean Buckner, who taught me all sorts of things. First of all, about how you look after visitors, which is least important. Secondly, we would meet every evening and discuss how things should be done. It was kind of English equivalent of going to the pub at the end of or the American equivalent of going to the pub at the end of the working day. And I saw two things which were very obvious to me. The first was that he, the number two in the whole outfit, had his own office on the clinical ward. So he was there where the action was with complex patients whose situation could change very quickly. And the third most important thing he said to me, he said, Tony, you're going back to an institution which has no tradition in this. You should start with the simpler form of transplantation, which is called autologous transplantation, where you support the patient's bone marrow with his or her own stem cells and not go into donor or what we call allogeneic transplantation until you have a formal setup which is properly staffed and populated at every level with every subgroup of staff. This was exceptionally sensible advice, and I heeded it, and I came back and started to treat conventionally some leukemic patients at a more intensive level than had previously done in that institution, with the object of having better outcomes despite the difficulties of that kind of treatment. And I looked to start autologous transplantation, which meant that you needed to learn how to freeze bone marrow cells in order to store them while you treated the patient before you put them back into the patient. And I was fortunate to have working with me a then junior colleague who's become extremely eminent, called Professor David Lynch, who became an expert in that area. And together, we developed this concept, which was pretty new to the UK, although possibly the Royal Marsden had done some cases beforehand. We developed it in the leukemia diseases, the lymphoma diseases, and at that time, which has not persisted, for some solid tumors, particularly carcinoma of the lung. So what I need to say to you, as I talked about the two stages because the environment needed to be built up. So that when I first went to UCH in 1976, the hematology ward was a Nightingale ward with the beds spread out in 2 rows on each side, with 2 cubicles at the end of each row on every ward. And that's where the tricky patients who might have an infection or might have low blood counts from leukemia or chemotherapy were put. And they were put in those side cubicles on several different medical wards. And as somebody recently described to me, so the ward round was like a safari, because you were not going to your own ward, you were going all over the hospital to the hematology patients in these side rooms. The serious practical implications of that were that you were dealing with a workforce which was different on every ward. The standards of nursing in that hospital were very high. Standards of ward sisters were very high, but if they had 2 leukemics on one ward and there were 8 leukemics across 4 wards, you were dealing with 4 different groups of staff, and this was less than optimal, of course, for setting up absolutely defined protocols of treatment and support. So what, I don't know whether you know the geography of that part of WC1, so I looked out of the at the side room on the 3rd floor of one of the old wards at which we were treating a leukemic patient, and saw across the road, of course I knew it was there, I'd looked at it, the private patient wing, which was 6 floors, at the ancient one from 1936. And the interesting thing about it was that all the rooms there were single rooms, because that was kind of the private practice of that time. And 2 of the floors were completely empty, but extremely dowdy looking across the road. And so I asked somebody, why are they empty? So it all fits together politically. These 2 floors had been closed by Barbara Castle, the then Minister of Health, because that was the Labour philosophy to reduce the amount of private practice. So I then went to the hierarchy and I said, well, can we have those 2 wards as single rooms to set up a leukemia unit? And they said, sure, but there is no money. And it was just not possible to use them in that form. They'd been vacant for a few years, and they were single rooms of the 1950s and 60s with none of the modern appurtenances. So what happened was to cut a long story short, my wife was connected to somebody working for a charity called the Sportsman's Aid Society, which was run by a bookmaker some of you will know called Joe Correll, and they took it on as a charitable project. Cost around 200,000. Not only did Joe Correll and his team take it on, but he brought the Queen Mother, who was a racing friend of his, to open it on the 9th of June 1981. And I can tell you at that time, lots of the internal decoration, so the buildings were done, but the way the rooms were fitted up was sponsored by a lot of individual people, including members of my own family, and that's how we got the leukemia unit started in 81, which allowed you to treat those patients in single rooms with a consistent trained workforce, which is up to speed with all the things that you were talking about, which blood tests you do, how you do blood transfusion, how you talk to the patient, how you order the blood, how you make sure it goes to the right patient, etc., etc. I'm sorry I'm spending a lot of time describing this. That allowed us to move up from the really slightly difficult side rooms of the general medical ward. This represented a kind of a major step towards becoming a major leukemia unit, and allowed us to expand the autologous marrow transplant program and to start rotating junior medical and nursing staff into a specific hematology ward and build up a major practice. That's what happened.
I'm going to ask you some more questions about that, but just before I do, just going back to your time in America, was part of the discussions and learning that took place there involved with risk of viral infection arising from blood transfusion? Did you learn anything different or hear anything different when you were in America than you had in the UK?
I didn't hear anything different, and in 1977, as far as I gauged the level of knowledge and engagement, it was about the same as ours in London. Their preoccupation was some of the complications of the donor versus the recipient marrow, which is called graft versus host disease. That can make the patient ill. That can lower the immunity to infection, and some of those patients then got infected because of that. There was not a greater emphasis on the risks of the transfusion of blood or stem cells than I had seen at home.
Moving then back to the centre, as you've described, setting it up, is it right to understand then that from the time that it was set up, so from June 1981, that your practice was then involved 100% with patients on that unit?
It was not that's not 100% correct. What is correct is that it's largely correct. So I reduced my direct appearance in the laboratory very quickly to virtually zero. We continued for a short period further to do the medical take, the general stuff, the heart attacks and the pneumonias and the stomach problems coming through the door. But I quickly took the decision that if this was to become, and I was ambitious, a nationally recognized leukemia unit, I personally could not continue with that work. So within a year or two, we asked the organisation to change the structure of the take firms, and we very much concentrated on clinical haematology alone.
And at the time you set the unit up, were there many other leukemia units in the United Kingdom?
There were, I think, at least two in London at the Royal Marsden and at the Hammersmith, which is become generically Imperial. Something in Birmingham, something in Manchester, something in Liverpool. I can't enumerate them all, but some of them had been established for a year or two or a few years before we attempted the one at UCLH.
And your service did become a nationally recognised service, a tertiary service. Is this right? Where patients were referred to you from other hospitals, from other centres? Yes,
I think that happened for two reasons. First of all, there evolved a realisation that the whole infrastructure, particularly of staffing, needed to treat these patients could not be sustained for many years in a district general hospital. So there was an increasing tendency to refer these very complex patients into the centre, and a centre in particular with which the district general consultant would have built up a relationship. One of the other things that I did to foster that was literally and I was busy enough, but to deliberately go out and spend time meeting them in their own clinics, and we would kind of have almost a mobile MDT, multidisciplinary team meeting for discussion, where I would go somewhere and they would present 3 or 4 of the most difficult cases, and we would say, okay, leave this chap here, you can do this, this and this. I think this individual needs to go to UCH, etc. And I would go to 3 or 4 hospitals, maybe once a month or once every 6 weeks each. And that fostered the relationship between the senior doctors and the referral relationship of patients. But the second thing that made us a bigger referral centre was that this autologous or self-stem cell transplantation caught on and proved, when I say caught on, became evidence-based to be a useful treatment, particularly for lymphoma diseases, Hodgkin's and non-Hodgkin's lymphoma, and to a lesser extent leukemia, and then in later years another hematology marrow disease called myeloma. And to this day, in 2022, autotransplant in lymphoma and myeloma remains part of the regular armamentarium. And so David Lynch and I started to do studies and publish in the autotransplant space, as I think the current terminology would be. And we also had a campaign to spread the message so that when autotransplant looked promising in leukemia, myself and Alan Burnett, who was then in Cardiff, were invited by those who ran the national leukemia trials, which at that time were under the auspices of the MRC, the Medical Research Council, to come up with protocols for the 2 main adult leukemias, acute myeloid and acute lymphoblastic leukemia, which we did. So we were testing the value of autotransplant amongst other treatments. So the UCH end of that got a national reputation in relation to that. David Lynch, who had started at the Middlesex, inherited a national lymphoma structure from his own mentor, a radiotherapist called Tony Jelliff, and David became the national leader of lymphoma, both in chemotherapy and autotransplant. And when there arrived a European structure to collect data in large numbers on these transplants as to how useful they were for patients, we quickly saw the possibility that running one of those registries would give us a lot of information, a lot of knowledge, a lot of ability to publish, and of course, let's be honest, a lot of referrals. So when the EBMT, the European Bone Marrow Transplant Group, announced that it was going to have separate registries for autologous transplant in leukemia and in lymphoma, at the next meeting sometime in the early 1980s, we went there with a view to applying for one of these and to take whichever was possible. I mean, this is a European organization with senior people from a large number of countries wanting these positions as well. To cut a long story short, the leukemia registry was our number one aim, but we didn't get it. But we got the lymphoma registry, which I managed for 12 years. That allowed us to collect data on, first of all, thousands of patients, and in later years, 20 years later, hundreds of thousands of patients, which although not randomized trials, gave a clear picture of what the outcome would be for a particular kind of patient. So across the board, we got a lot of referral because David was running lymphoma studies in the UK, which involved transplantation. I was running with Alan Burnett, AML, acute myeloid leukemia studies for the MRC. I was running with an American group called ECOG, the Eastern Cooperative Oncology Group, the transplant trial for ALL, the adult acute lymphoblastic leukemia, and we were managing the EBMT registry in lymphoma. So all this massively raised our profile and kept us extremely busy.
Can you tell us a little bit about why patients with malignant hematologies need treatment with blood components? So first of all, can you begin by explaining why patients with leukemia need blood component therapy?
Yes. So what are called the acute leukemias are diseases of stem cells which often proliferate very quickly. These stem cells usually mature into mature white cells which defend us against infection, and mature platelets which prevent abnormal bleeding. When that evolution does not occur, the bone marrow becomes overrun by the most primitive cells, which are usually the normal precursors of these cells. These are called blast cells. And this poses you two kinds of problems. One is that the very disease itself will lower the platelets, very low indeed, and potentially cause the patient very significant bleeding. The lowering of the white cells, because they don't mature, would make that patient, even before you do anything, very susceptible to infection. And the replacement of the bone marrow by these cells which never mature, called blast cells, means that what we call normal hematopoiesis, the normal development of the stem cells of all these different lines, doesn't occur. And the patient, in addition to having no useful white cells and no useful platelets, I generalize to make the point, becomes severely anemic as well, because the red cells don't get made. So first of all, even if you don't attempt to eradicate the disease, in order for the patient to live longer, to be supported or palliated if you're not going to go for what we call a remission, they need red cell transfusion, and they need platelet transfusion. Granulocyte transfusion came in much later, was technically much more difficult, and it's doubtful in most cases whether it ever did more, that's putting in the good white cells, than giving very good broad-spectrum antibiotics. So there's a big supportive element to replace these things that are not getting made. Now, the next problem is, in order to bring about a remission, which takes them back to a normal blood count. Remission means everything looks okay. It may or may not mean there's no minimal residual disease still there. So in many of the cases, particularly the myeloid ones, in simple terms, you have to clear out 99.9% of those blast cells from the bone marrow, because it's like, in simple terms, it's weeding the garden, because somewhere in there are some remaining normal stem cells, and they will regrow when you remove the others. Now, the problem of that is that you need very aggressive chemotherapy to be able to do that. So you have a situation where the patient has already got low elements of the count, but in order to put them into remission, you literally have to make things worse before you make them better. So that means you have to put them, you have to give them about a week's regime or 10 days of complicated 2 or 3 drugs, which will lower all those elements of the blood even more. And so and the recovery, well, not if you're lucky, recovery, if you give the right treatment and the patient has the right kind of genetics in the bone marrow, will occur during approximately the 3 weeks after that. So you've got a month where in the first week you're making them worse. Weeks 2 and 3, all the elements of the blood count are right at the bottom. And in the 4th week, hopefully, the white cells and the platelets begin to come up. You're less worried about the red cells because they're more easily topped up by transfusion. And during that period, the patient is often very sick, unwell, inflamed mucosal surfaces, so that the mouth and the bottom can be very sore, and some of the skin crease areas. They're very susceptible to infection, so you would want them in a single room, and in an ideal situation with even the air going in being filtered so that they're not getting susceptible to the bugs which other people are carrying but are not harming them. And you need an expert team to keep an eye on them literally for 24 hours. It's not intensive care medicine by definition, but that first week is pretty much, in some circumstances, towards intensive care medicine. And these kind of treatments, which need support with blood and platelets, often need repeating in AML, the commonest and most severe adult form, 2 or 3 times before you are... Sorry about that. I thought I'd switched it off entirely. Need repeating 2 or 3 times before you are sure that there is no residual disease, or as little as you can get. That means giving the patient a heavy treatment, letting him or her recover, go out for a little bit, and you almost have to be cruel to be kind, because the period you send them home has to be short, because you have to start the next treatment before there's a chance to regrow the disease. So, to go back to the beginning of what you asked me, in the mid-1970s, when I arrived at UCH, there was no real intention to attempt to induce a remission. That's what doing this difficult treatment is called, in every single suitable adult patient, because those around thought the side effects were too difficult, the failure rate was too high, the patients wouldn't want it, and the outcomes were poor. So from what I had seen in Cambridge when I was training as a senior registrar, and what I saw in Seattle when I went to the transplant unit, there was much more that could be done. So we took the view that the way to help these patients was actually to intensify the treatment to get them into remission, to empty the marrow adequately and not give up. And to do that, you needed that environment of single rooms, which we got in 1981. And also you needed, and I was extremely thankful to a guy called Tim Jackson, who was at that time, followed by another guy called Steve Rowley, who were the most senior of the specialist nursing staff in haematology, who put together in that new leukemia unit a very strong team of very highly qualified nurses, and we attracted junior doctors at senior registrar level who wanted to train in leukemia, and we steadily built up a specific leukemia unit which did a lot of autologous transplantation. We didn't, and we did the first autologous transplant in 1980. That was done in the side room of the Nightingale ward. And then we specialized in that in the new leukemia unit and did not attempt an allogeneic transplant till 1988, till the younger patients who needed an allogeneic transplant, we referred elsewhere in the intervening years till we had built up the unit. But what I should say was that unit, which was the old private patients wing, was still not good enough in modern terms. We had the ethos and we had the staffing, but the environment was not good enough. So one of my personal objectives in being the medical director was, of course, to serve the hospital in general, but actually to build up the leukemia and the cancer services and to get a new hospital built, which for years was agreed but oscillated in final geography between the old Middlesex Hospital campus and the UCH campus close to UCL. And to cut a long story short, that new build was agreed before I stepped down from being medical director in July 2000, and the final decision was on the UCH site because, in my view quite correctly, but maybe I would say that, because of the proximity to the academic environment and the supportive science at UCL. And in the planning for that new building, then we factored in the new building single rooms with the appropriate filtration and ventilation so that these patients could be optimally treated, and finally moved in. So the build itself took 5 years, and finally moved into that in 2005, I think it was.
And just returning to the question of why patients with leukemia need blood treatments, what are the risks to them if they don't receive blood component therapy? So, for example, by platelets or red cell transfusions. You've told us that they're very susceptible to infection, and also just as a result of the disease itself, susceptible to bleeding.
Yes.
Can you tell us a bit more about that? How does bleeding occur? Can it be very serious? Can it be life-threatening? Can it happen very quickly? What kind of bleeding would such patients be at risk of?
Yes. I will do that. The disease and the drugs to induce the remission often reduce the platelet count below 10, which is at a very high risk for bleeding. And the bleeding that occurred in leukemic patients could occur anywhere. Most often probably occurred from the gut, but the bleeding that you were most you're worried about all of it, most seriously worried about would be in the brain or in the eye, and then you would try to support the platelets during that treatment so that significant bleeding did not occur. The red cells, the anemia, was not a problem at the same level. First of all, the counts didn't fall as precipitously, and secondly, it was generally easier by intermittent transfusion to keep the anemia count up to a reasonable level, which is not only important in particular for the heart and lungs, but the general strength of the patient to tolerate the aggression of the treatment that you were giving to try and clear out the bone marrow. So there was intermittent, what we might have called topping up of the red cells. But in the first years, in the mid-1970s, a big emphasis on giving platelets with that aggressive chemotherapy to induce a remission, which was often several times in a week to give platelets. Sometimes you did not see much of an incremental rise in that platelet count, but so it was a very difficult situation that because you were keeping them well and no bleeding was occurring, you were using the numbers perhaps too much as the threshold as when to give the next lot of platelets. So in the first 3 to 4 courses of AML treatment in an adult, we would give very intensive platelet treatment at the time of the week of the chemotherapy and in the couple of weeks of a very low count. So a patient may 3 or 4 times have 3 weeks of platelets in which they were getting platelets 2 or 3 times a week.
And are you describing there a program of prophylactic platelet transfusion?
Largely prophylactic.
And so what were the advantages and disadvantages of providing prophylactic platelet transfusion to patients? What was the balancing exercise that you went through when deciding whether to do that or as required?
Some of it related to the threshold and the number you thought was a safe level above which the platelets needed to be to prevent bleeding. There was some consensus about that, but not total. Some of it related to the fact, concern related to the fact that the platelets themselves were not without risk. In the early days, what I would call the early days, the mid and late 1970s, the focus of that risk was less viral infection, and I'm not saying whether that's right or wrong, but the focus of that risk was 2 things which happened to the patient. One was allergic responses to platelet transfusions, which may have related to some degree of incompatibility between the blood groups of the minor blood groups of the donor and recipients, and may have related to some of the other components of the platelets, such as the donor's white cells or leukocytes, which may have contaminated that platelet transfusion. So the patient physically, frequently, because of the frequent use of platelets, had an allergic response. By that I mean an itch or a scratch or an allergy or semi-asthmatic attack, very rarely an anaphylactic attack, but an allergic response. And the second consequence of using a lot of platelets was that the recipient became refractory to them, and that the counts did not rise to the level at which you were thinking would be the safe level to prevent bleeding. And that was often because the patient, the recipient, made antibodies against the platelets, and they destroyed the platelets pretty soon after they were given, so that you could see no numerical advantage to giving them. So you were left with the problem that you thought you had to give more because the numbers weren't going up, but the more you gave, in some patients there was an allergic response, and then they became refractory. So you had to consider a different approach.
So about to look at some of the guidelines. I notice it's 20 past 11. I don't know whether now would be an appropriate time to take the break.
Well, let's take a break now then, shall we, for half an hour and come back at 10 to 12.
Okay.
Now, this is the first break in your evidence. What I say to all witnesses is that you're giving evidence. You must not talk to anyone, whoever that person is, about the evidence you have given or anything you think you may yet be asked about. You can talk about anything else you like. And I look forward to seeing you back here at 10 to 12.
Thank you.